Firstly, thank you for shortlisting us. My name is Ruchi, and myself and Dr. Ali Al-Zakman will be sharing our QIP. This was a collaborative project between medicine and radiology, looking to improve the quality of X-ray requests to check the position of nasogastric tubes. A nasogastric, or NG tube, is a tube inserted into the stomach via the nose for the purpose of nutrition or medication. An incorrectly sited NG tube is classed as a never event, akin to operating on the wrong patient or on the wrong limb. This was recognised as a national issue all the way back in 2005 by the National Patient Safety Agency. Despite the early recognition and resources put towards this, it remains an issue, and 32 patients died between 2011 and 2016 as a result of incorrectly sited NG tubes. And almost a quarter of these errors in 2020 were due to errors in the position checking process. Not only is this a national issue, but we identified this as a local issue as well, and recently UHL had a similar incident. This echoes our own clinical experience where many X-rays had inadequate information. This could not only lead to patient harm, but also delay in patient care, and patients and relatives would be distressed that their loved ones were being starved until an NG tube was confirmed safe to be used. The aim of this project was to have clinicians request X-rays with the right information the first time.
In terms of our methods, so in March 2021, we collected data from CRIS on NG tube X-ray requests in different clinical management groups, or CMGs. We identified that the Emergency and Specialist Medicine CMG group has the least adequate information in their requests. And then what we did was we collected the relevant data. In September 2021, for our first cycle, we sent out a summary of the UHL guidance to doctors, and then we collected that data. And then for our second cycle in February of this year, we implemented mandatory prompts asking for specific clinical information as laid out in the UHL guidance. And then we collected that data as well. To demonstrate the new ICE prompts, so previously on ICE, clinicians were given a free text box to give clinical information. Now ICE takes the clinician through the clinical information to ensure the UHL policy is practiced. So the key clinical information being the purpose of the NG tube, whether aspirate was obtained or not, and the length of the NG tube. And of course, as you can imagine, as any major intervention, to make it happen, it required a lot of hoop jumping. And this particular intervention was taken all the way to the Deputy Medical Director and Chief Medical Information Officer. And had it not been for the close collaboration between medicine and radiology, this probably would not have been possible. So going back to our previous illustration, when comparing our baseline results with the results after our first cycle's educational intervention, we unfortunately don't see much in the way of improvement. But after we've implemented our mandated ICE prompts, that's when we really hit jackpot, because as you can see, results were very promising and successful, demonstrating 100% UHL policy practice. And this is just to visualize the results. So this is a runner's chart. On the y-axis, we have whether they include the information or not, and on the x-axis are each individual request. And the dotted lines demonstrate when we intervened. Okay, so our baseline data was mixed, and this continued after our educational intervention, but changed drastically after our ICE intervention. And here we see an average percentage compliance per cycle. So again, as you can see, the first cycle did not harbor much improvement, but the second cycle achieved 100% compliance to protocol.
To summarize, our baseline audit showed ESM was the worst performing CMG, with only 39% of X-ray requests at baseline having adequate information. Our first intervention, which was the educational intervention, made no significant impact on the quality of information provided. It was our second intervention, the changes to the ICE requesting process, which had excellent positive impact with 100% compliance. To conclude, we achieved 100% compliance in all three parameters required to justify a check X-ray for nasogastric tubes. This will likely have similar impacts across other departments. And most importantly, patients will receive safe and timely care for the nasogastric tubes. And finally, some just acknowledgements. Thank you to the following people, especially IT, for their help with coordinating and facilitating the changes on ICE.
Thank you very much.